All right, let's go ahead and get started. So this lecture is on postoperative nausea vomiting, as you can see. So it's a little bit lengthy of a lecture, so we're just going to go through the first half today, and we'll go through the second half next month. Let's go ahead and get started on nausea and vomiting after an anesthetic. And this is called postoperative nausea and vomiting, but it's really just after an anesthetic. You can have these after MRIs or things where you weren't really undergoing surgery. So just kind of keep that in mind. So here's kind of the things we'll go over. Today, we're going to go over kind of talking about the problem and the prevention of it. So probably the more boring aspect of this whole lecture. Sorry. But next month, we'll go over all the drugs. I think that's a good kind of stopping point. And the reason I was bringing that up just in general is because there's like, I think I have 40 slides as a part of this PowerPoint. So I didn't want to have to just completely cook through that as fast as I possibly could. Yeah, so we'll get through it. So we're gonna kind of look at what this is, look at different prevention, risks, things like that. And then we're also going to look at the next lecture, we'll go over the drugs and how it's treated and things. So the first thing, of course, define the problem. So what is postoperative nausea and vomiting? So this is basically nausea and vomiting after an anesthetic. And why is this an issue, right? So first off, it's a really big patient outcome. When patients are filling out, surveys and giving feedback, this has a lot to do with their satisfaction of a surgery and of an institution. Is how well did you take care of this? Anyone that's ever had surgery and was puking afterwards, I've had that myself. It's not fun. You already feel like crap, and then you feel like more crap. And so anything we can do to prevent that really helps out a lot with satisfaction. And I'll go through it on the next slide. There's some negatives other than just throwing up and feeling bad. There's some real tangible negatives that can come from this. It does delay discharge from PACU, and in severe situations, and I've had patients that have had this intractable nausea and vomiting, and you have to admit them to the hospital. So unplanned admissions is kind of a big metric here, and especially like now, I look at RSV in the winter months and stuff. We don't have beds over in pediatrics, at least, to be admitting people for nausea. So if we can treat this before it starts, that is awesome. Depending on what you look at, and we'll go a little bit into this a little bit later, it can occur between 30 and 80% of all adults and children after an anesthetic. That's a huge range. That's like saying from 0 to 100. It depends on risk factors. It depends on what kinds of surgery you're doing, things like that. But the burden's pretty high. It's not like an occasional thing that you're going to get like postoperative delirium or something like that. This is something that happens a lot. Which I'm kind of preaching to the choir because this is for a lot of PACU nurses, and y'all know people be puking. PDNV stands for post-discharge nausea and vomiting. And so this is the nausea vomiting stuff that we don't see. Patients go home and they're sick. And this is just kind of a quality of life issue. And then for, could run into some of the problems that we'll list here in a second. One metric noted that this happens in 37% of people. So we get them nice and controlled here, and then they go home and throw up. Some surgeons are kind of combating this by writing prescriptions for things like Zofran or Phenergan or something like that people can take at home, just because narcotics can cause so much of this in people. So here's some of the big problems you can run into with a lot of nausea and vomiting. Wound dehiscence is a big deal. If you have an abdominal wound or something like that, you are sitting here retching and causing your blood pressure to go up. You can actually tear open the wound. Esophageal tears and ruptures. Yes, you can throw up so much that you just destroy your esophagus. Go ask any gastroenterologist, and I bet they've probably seen one that week. Aspiration is a big concern. If you're having vomiting before you've fully been able to wake up and protect your airway, or in some patients, just in general, they can't protect their airway, aspiration's a big deal. Patients can get dehydrated, which is a little less of an issue because they have an IV and we can counteract that, but it's still an issue, especially if they go home and have post-discharge nausea and vomiting. This massively increases intracranial pressure. So I don't know if anybody has been real sick before, but if you are throwing up a whole lot, your head hurts like crazy. The reason your head hurts is because you're squishing it. After a procedure, especially after some sort of cranial procedure or carotid, something like that, you can really wreak some havoc just by having some nausea. Pneumothorax is another concern that it can apparently happen when you just retch a whole lot. You can drop a lung. I mean, these are real things that have measurable significance. Another thing with the aspiration that I've always been taught, and this just sounds miserable, if somebody has some sort of OMFS, like jaw surgery, and we have to wire their mouth shut, it is absolutely critical that you keep them from having any sort of nausea and vomiting. Because as you can imagine, if your teeth are wired shut and you're trying to vomit, even though it's probably not solid, we're going to get into some gross stuff here, even though it's probably not solid, the volume of it that could come up could go faster than what can filter through the gaps in your teeth. So it could be a real big issue. Yeah, I'm glad we're doing this in the morning where I can gross y'all out. So if I were a smarter physician, I could walk you through this drawing like crazy. I could really get you through the different mechanisms that feed into this whole nausea vomiting loop, right? And there's not just one, there's several loops and there's several receptors that actually cause all of this to happen. Some of them are central mechanisms, some of them are peripheral mechanisms. They're kind of listed on this chart. I'm not going to get too down in the nitty gritty, but what I want to drive home to you guys is that this is a multifaceted area. We can't just give everyone Zofran and it work every time. And here's why. It is complex. There's a lot going on. Centrally, you've got H1 histamine receptor is a big player. M1 acetylcholine is a big player, and dopamine can also be a pretty big player in this. When we talk next month about pharmacologics, we'll go into exactly which drugs target those different receptors, and you'll go, oh yeah, that totally works that way. There are peripheral mechanisms as well that can occur actually in your gut. These are in, they drive substance P and serotonin. Serotonin's where, Zofran works. You see in the kind of the bottom corner, I think I can turn on a laser pointer. Oh my God, this is so cool. So down here, can you see it? Oh, this is so cool. So here's my little laser pointer. So down here, these enterochromaffin cells will secrete these things and you get feedback back in your brain and that makes you want to puke. And so even up here, you can see opioids and anesthetics, meaning traditionally inhalational anesthetics, work up in there. Chemoreceptor trigger zone is one area that's kind of a buzzword. There's another area. I don't know. Anyway, and they've renamed them. I don't even think the chemoreceptor trigger zone is what it's called anymore. Now it's called something different. But either way, there's a lot going on. There's a lot of things that bother it. That's the bottom line. Different risk factors. There's a lot. I don't even think this is that exhaustive of a list because I bet you we can find more risk factors. for different things. So there's, I kind of split this into 3 categories. So if you just look at the patient, what kind of risk factors does the patient have? If they have preoperative nausea and vomiting, well, guess what? That's probably not going to go away immediately. So that's a risk factor. So you'll see this in people that come in for like any sort of bowel surgery and things like that, which there's a lot of risk factors. But if you've got a lot of nausea going on already, if all the mechanisms on that last slide are already all ramped up, it takes a while for that to go down. And so sometimes the pre-op nausea vomiting just occurs post-operatively. The female sex has more nausea and vomiting after a procedure. I don't know why. This is post-pubertal, like child females under the age of 10 or whatever, don't have any different nausea and vomiting than their male counterparts. But once you go through puberty, you have more nausea. If you have a history of post-operative nausea and vomiting, if patients will come and tell you, at least when I'm doing my preoperative visit, my pre-op exam, that's a big thing that pulls up. Anyone with a history of motion sickness, basically because we're going to replicate motion with drugs, right? That's a big risk factor. Interestingly enough, non-smokers have more nausea and vomiting after procedures. Smoking is a protective factor for this one thing on the planet. If you're a smoker, you have less nausea after an anesthetic. Age under 50. So as you get older, you apparently have less nausea. So you're higher risk if you're under 50. You're also higher risk from ages 3 to 10. Kids under the age of 3, and this is on another slide somewhere too when we talk about scoring scales and stuff, kids under the age of 3 do not really have nausea and vomiting afterwards. They may spit up, but from what we have ascertained as a medical community, it's not actually nausea that's causing the big issue. Having said that, the caveat is most of the studies don't measure nausea in a baby because babies can't tell you they're nauseated. And so it's really the marker's vomiting. Whereas in adults, we're looking at both nausea and vomiting. So whether you've actually vomited doesn't matter as much. If you're nauseated at all, then, that's PONV. So that's kind of I guess a little misleading. Chemotherapy-induced nausea and vomiting. People on chemo throw up a lot, and they have their own weird drugs and regimens that take care of that in huge doses. Like they'll get like 50 azofran and stuff like that. I've seen. And they now have much better drugs that probably you don't have to way overdose people on, but that's the whole thing. So anesthesia risk factors, what things are going on during the anesthetic that makes you at an increased risk? A general anesthetic is technically a risk factor for nausea, mainly with inhalational anesthetics, okay? TIVA, which we'll get into a little bit later as well, that is total intravenous anesthetic, creates way less nausea than does inhalationals. A protective factor that we can do as an anesthetic, apparently using ketamine can be a protective factor. Propofol as well causes less nausea, and so I kind of added those in there. Nitrous oxide is theoretically a risk factor, though it's been challenged lately. That's why nitrous, I think, has fallen kind of out of favor with a lot of anesthesiologists. We still have people that use it very routinely on things. But I don't use it a whole lot after induction, mainly for this reason. Duration of anesthesia. The longer you're under, the more you want to throw up afterwards, okay? So little short procedures are lower risk, in other words. And then, of course, opiates. Anytime we give opiates to people, that can cause that problem. Different surgeries that are risk factors. So, and why these specific surgeries, sometimes it makes sense, but not necessarily other things. So lap choles are at high risk for nausea, mainly because we manipulate the bile duct in the bile tract, and that can cause some issues. I kind of tell people anytime we go in the belly, which is that third point on here is laparoscopic. I'm pretty sure from that I meant abdominal laparoscopy. But any sort of abdominal surgery where you go in there and you're messing with the intestines, they release different chemicals and things like that, and just make you kind of sick to yourself. GYN procedures are high risk, as is pretty much any genital surgeries for people, which is at the bottom of that list. I'm going all sorts out of order. Tonsillectomy and adenoidectomy. These are traditionally big risks. Sometimes the patient can swallow a lot of blood that you don't know about while they're sleeping, and promptly that really pisses off the stomach, and they'll throw that up afterwards. Strabismus surgeries, anything with eyes that can cause your different receptors and stuff to be thrown off, as well as otoplasties. Anytime you're working in the inner ear especially, that is a high risk procedure for nausea. Inguinal hernias, this one I didn't know. I thought inguinal hernia stuff was pretty chip shot kind of procedure, but apparently it's a risk factor as well. Yes, ma'am.
So if someone has a bunch of risk factors, say they're going in for a long surgery, can you said the inhalational increases your risk. So you can do like any length of surgery with just IV meds? Like when do you determine? You
can, but every choice has its consequences, right? We'll go into kind of TIVA here in just a second, but yes, you can, theoretically, any surgery can be done without inhalational anesthetics. Yeah. Okay. Any surgery could be done that way. It's a lot easier with inhalationals. The more difficult or the more complicated you make things, the more difficult it is, and you open yourself up to some problems. And we'll go into that here in a little bit. Okay. Any questions on any of that stuff so far? Okay. The next thing we'll go into is prevention. How can we keep people from doing this? So there's a couple of different strategies. One of them is to minimize their triggers, right? Let's minimize the amount of things that are going to make them, have nausea and such. So a big thing is multimodal analgesia, right? And opioid sparing is kind of part of that. So instead of, back in the day, you have a big surgery, we would just take a lot of narcotics, and to some degree we still do, again, because it's very easy, just dump a bunch of Dilaudid into you, or fentanyl, and not use any other, no local, no other medications. That is, there's more and more evidence that shows that that's not a great way to do it. Add some acetaminophen. We got, NSAIDs. We've got gabapentinoids and things like that. That we can use to help out with pain, help out with analgesia that isn't increasing your risk for nausea. Another thing we can do is adequately hydrate people. We know that if you don't give much fluids intra-op, then you can run into the problem of nausea. On the flip side, a lot of ERAS protocols and things now call for much less hydration than we used to do. So it's kind of like the Goldilocks thing. Not too little, not too much. Risk stratification is also another big deal. I need to actually seek out the different problems that somebody can be coming to the table with. What are their risks? How severe also could this be? Like I said, when you're wiring somebody's jaw shut, like how critical is it that we keep someone from vomiting? Is it going to cause really big issues and problems? And then another prevention strategy is to just look at prophylaxis. Most of this is prescription drugs. There's a couple other things that we'll get into next month, but most of it is what medications can I give you that will reduce the amount of nausea and vomiting that you possibly have. So I cannot stress this enough, that this is a simplified scale. This is dumbing everything down. as for a quick little scale that you can use to determine someone's risk for postoperative nausea, vomiting in adults, and then postoperative vomiting in children. So on the left side, we're going to look at the adult scale. So this is a quick 4-point scale that correlates with someone's percentage risk of having nausea. So on this particular scale, and I did make a whole slide just for the citing on here. This is from Society for Ambulatory Anesthesia from 2007, it looks like. And so in 2007, I guess they decided to dumb the whole scale down to this. That's so easy to use, you can't screw it up. So female gender gets you a point. Being a non-smoker gets you a point. History of postoperative nausea and vomiting gets you a point. And postoperative opiate use gets you a point, right? So the number of risk factors just below that can go anywhere from what looks like 10% if you have no risk factors, up to 80% if you have all 4 of those risk factors. That sucks. So if a female comes in for, let's say, hysterectomy, she doesn't smoke and she's vomited before or after procedure, that apparently puts her at an 80% risk of having nausea afterwards, which is astronomically high. But even if you're just a female who doesn't smoke, that gives you that's a 40% risk right there. So the big point of this whole thing is that it compounds a lot, and it doesn't really, for a lot of people, I can't change the fact that you're a female and you're a non-smoker and that you've had a history of postoperative nausea, right? I can adjust the opiates thing. It may not be a great idea. You know, it may give you really crappy analgesia or something like that, but I can adjust it. And so even with just those few things going on, you still have a really high risk. So now let's move over to the children's side or whatever. So again, I mentioned this earlier, it's hard to assess nausea in little bitty kids. So this whole scale is based off of who vomits afterwards. So the percentages are a little bit lower, but it's still an issue. So for kids, for whatever reason, the duration of surgery meant a lot more than in adults. So surgery over 30 minutes, greater than or equal to 30 minutes, gets you a point. Age over 3 years, again, under 3 years, apparently this is way less of a problem. Strabismus surgery in this particular scale for these particular people got you a point. And you know, why that surgery and not any of the other ones, I guess that's the most high-risk surgery for it. And then a history of either postoperative vomiting in that particular kid or any postoperative nausea, vomiting in relatives, which is wild that I came across this because I did not believe that was actually a hereditary thing. I've always told my patients that's not usually something to worry about. This taught me something new. The citing for this scale is under B. This was from 2014, International Anesthesia Research Society put that together. So again, this is kind of the stuff we're faced with. So from the kid scale, if you have 0 risk factors, that looks like about 10% or so. Going up to 1 risk factor does not jump it up very much when compared with this over here on the left side, right? So having 1 risk factor for an adult doubled your chances. Over in a kid, not so much. But then you see when we go from 1 risk factor to 2 risk factors, then we're getting into 30%. 3 risk factors put you at 50%, and 4 over 60, right? So this is an issue in kids as well, right? Just as a side note, kids dehydrate much quicker than adults. They can throw up a whole lot. For anyone that has kids, you probably know that. They're like Cocker Spaniels. All they do is throw up and pee. I think I stole that from an Adam Sandler movie. But either way, that's the thing. So, does everybody get this? Quick little chart type thing. All right. We will skip on over to this. Now we'll talk about TIVA. So here's something that can be done, right? Anesthetic technique can be altered. So if I get somebody that's super high risk for nausea. There's things I can do to help reduce that. Some of that is me just giving them drugs, but another thing that I could do is adjust my anesthesia for it. So we talked about this earlier. TIVA stands for total intravenous anesthesia. This is where I don't give any gas. At least in a perfect world, I don't give any gas. There are hybrid versions of things. So there's gray area between. So I can give just a little gas and a bunch of IV stuff or, you know, stuff like that. But when I am running a TIVA, I run a TIVA. I don't run any gas, right? If I'm going to get the benefits of a TIVA, I'm going to go all the way. So how do we do that? What agents do we use? Propofol is almost always on everybody's docket. It's cheap, it's reliable, it's easy, it doesn't have a whole lot of side effects, and it's pretty short acting. So if you run it as an infusion, you're not asleep all day, right? You come out of it decent. Also, propofol itself is an anti-nausea medication. So that's kind of a protective factor and why people use it in TIVAs. Ketamine can be used. Some people will mix propofol and ketamine into this ketofol slurry. That's very commonly used in ER settings where you want, because ketamine will provide some analgesia. But ketamine comes with its own kind of side effects, and so some people don't like using it because of that. I'm one of them. I think people waking up crazy is not good. Dexmedetomidine, this is also known as Precedex. This also works real good in a TIVA situation. Remifentanil, many of you may not be real familiar with it, but remifentanil is in the fentanyl family. So it is an opiate narcotic, but it has a super, super short half-life. And so when you use it as an infusion, you can get some profound depth of anesthesia because you can really hit all those receptors and knock them down way harder than you can with something like morphine, Dilaudid, regular fentanyl, that kind of stuff. But when you turn it off, it's off in like 5 minutes, 10 minutes, something like that. So it's really short acting. Midazolam is another thing that you can use as in a TIVA setting with that category of drugs. These are not like mutually exclusive. Very rarely will I do a TIVA on only one, like just propofol, right? I'm going to mix some stuff together because it is just so much better. It's hard to do a surgery with just propofol, right? I can make you totally unaware what's going on, but propofol does not do much for immobility. It doesn't do a whole lot for analgesia. So you can run into some problems with that. So we gotta stack some other stuff in there to make it work. Okay, so I didn't really answer Ginger's question earlier in the video. There are definitely downfalls to running a TIVA. For example, the incidence of awareness will go up significantly while running a TIVA. There's also the emergence phase to consider. When you run a really long and deep anesthetic in a TIVA manner, it'll definitely take you longer to wake up. You've got all these drugs in your system, you've got to metabolize them and get them out. So when you run infusions for a long time, the emergence will also be longer. Also, cost will be significantly higher when you run a TIVA on these patients when compared to inhalational anesthetic. Those are just 3 real quick examples of why we don't run a TIVA for everybody, and I just thought they should be addressed here. Let's say I don't even want to put you to sleep at all. Let's say I just want to help numb up the area that we're working. So we can do regional anesthesia as well. Real popular thing for knees and hips and stuff is spinals. You can also perform a full-on surgery with an epidural. So if it's going to be, spinals are great. They're real dense, but they have a shelf life, right? 2 hours, maybe 3, and that thing's wearing off. And so an epidural is kind of cool because you can just keep adding medicine to it. You can also do a combined spinal epidural for some of these things where you want the benefits of a spinal, but also want the longevity of an epidural. Peripheral nerve blocks are great for things like hand surgeries, leg surgeries. Again, peripheral means not so much the trunk of your body. That's a lot better obtained with like epidural and spinal. But anything in your limbs, we can numb up like really hard. And then there's certain situations where just maybe local from a surgeon's good. A good example for this here is carpal tunnel surgeries with neurosurgery. They like to just put in their own local and do it that way. They seem to have really good results. That works. Can I put someone to sleep for carpal tunnel? Absolutely. We do at health center all the time. So it's just a different preference there. So now we go on to hydration. I had mentioned this earlier, that having an adequately hydrated patient will help out with their nausea afterwards. I know this because of science. So this whole lecture, by the way, is put together basically from the up-to-date article on postoperative nausea and vomiting. I think it's it's really good. I think it might be a little biased towards like one institution, because I think a bunch of people from one institution wrote it. That's not necessarily bad. It's just their kind of viewpoint of things. But anyways, they quote a whole lot of different, articles and research into some of these things. Just as a quick refresher to those that don't remember, a meta-analysis is where you take a whole bunch of different studies that are similar and you put them through statistics and basically lump all those patients together and spit out a result to see if what one study found is actually what's going on. Theoretically, it is the most powerful form of data, because it will be able to show you if some of these studies were a fluke or not. You know what I mean? So when things on my presentation, a meta-analysis, that usually is really good evidence, in other words. So this first point, liberal crystalloid fluids reduce the risk of late and overall postoperative nausea and vomiting when compared to restrictive fluids. What did that mean in this? And I didn't want to get too wrapped up in how many studies and how many patients and things like that. But like some of these meta-analysis will look at 15 different studies and pull together 12,000 patients, you know what I mean? So you're getting big numbers with some of these things. And some of the meta-analyses are not. Some are 4 or 5 studies and they involve 100 people, you know what I mean? So that stuff does kind of matter, but the take-home message is this. When you give more fluids, at least this meta-analysis showed, when you give more fluids in the 15 to 30 ml per kilogram range, that reduced the risk of overall nausea and vomiting compared to restrictive fluids, which is very restrictive. 0 to 2 mLs per kilo. That's pretty tight. I think it's real easy for anesthesiologists to give fluids because we just kind of open it up, and when we forget about it, next thing we know, we gave way too much fluids. But I use this piece of knowledge to guide how I do pediatric anesthesia. Mainly because for like an adult, you just give them a bag of fluid and you're kind of somewhere in that range, you know what I mean? Or at least kind of close to it. For kids, you could drown them if you're doing it wrong, or accidentally give them no fluids if you're using a Buretrol or something like that. So 15 to 30 mLs per kilo is pretty good. In terms of pediatrics, if you'll remember, if ACLS and things like that, if a kid needs a fluid bolus, it's 20 mLs per kilo with crystalloid. So that's right up there with what this is. Another meta-analysis showed at least 10 mLs per kilo would help prevent nausea and vomiting compared to lower amounts of crystalloid. I have crystalloid underlined in both of these. Crystalloid means normal saline, lactated ringers, plasma light, some version of that, right? I am not talking about blood or albumin or head of starch or any of those other weird things. Those are all colloid fluids. We're talking about just crystalloid, looks like water. There was a pediatric trial that this thing mentioned as well, that during strabismus surgery, 30 mLs per kilogram per hour of LR decreased postoperative nausea and PONV at 24 hours compared to 10 mLs. So again, giving a pretty good bit of fluid for these procedures is a protective factor. I'll pause here and say that there are situations where you would not want to give this much fluid. I mentioned earlier ERAS, enhanced recovery after surgery. There's a lot of ERAS protocols that show, especially for bowel surgery, more fluid is counterintuitive to what we want to achieve. Yes, it'll reduce nausea, but it will swell the bowel and cause more ileus and problems like that. So this also needs to be tailored to what you're doing and what your goals of what you're doing are. So there's certain reasons why we would not want to give 15 to 30 mLs per kilo of fluid to a patient. And maybe in those situations, we need to look at other ways to help prevent nausea. As a last little note on this slide, IV dextrose fluids were investigated. Hey, let's give these people some sugar and see what goes on. It looks like it's all BS. I don't think that, based on what I've read and things like that, it looks like it's pretty mixed results and it doesn't really work. Let's just stick to crystalloid with no dextrose in it, which is pretty standard for working in an OR setting. So with that did take a long time. With that, I'm going to stop and we will cover the rest of this stuff at another date in January, I guess. Mm-hmm. I will go through the rest of this because I'm only on slide 14 of 32. So we got a lot of ways to go.